Thank you. So good morning, everyone. Welcome to House Bill 3046 RAC meeting number 3. Welcome to the RAC members and other interested stakeholders and Division of Financial Regulation staff. I'm just going to start by briefly summarizing our last meeting, the discussion items that we covered related to mental health parity and the reporting requirements. And so we discussed the draft rules, the discussion draft of rules, and we covered topics such as the need for clarity for what incentive payments are with respect to calculating the medium maximum allowable reimbursement rate, along the lines of to include contracted rates and or incurred claims. And we'll be going over the red line rules here in this meeting. We spent time discussing denials, what constitutes partial and full denials, examples of what those might be, all around how to report them appropriately. We discussed claims and the fact that there are really no partial claims. Claim's a claim. And we also reviewed and discussed at length the variety of non-quantitative treatment limits, reporting collection tools, and the different formats that are available that different states are using. And we discussed some of that. And also it was voiced that insurers have a desire for some flexibility with respect to that reporting process. We did request written comments to be submitted by September 16th. And we will take some time today for the submitters to just briefly summarize their comments. And I think that was essentially where we left it. And I think we should go ahead and get started with today's agenda.
Awesome. Thanks, Lisa, for a recap of what we discussed last time, 2 weeks ago. Wanted to provide a little bit of time at the beginning before we launch into our discussion. We had several of the RAC members provide comments. So want to just give you all a couple minutes to talk about your comments with the group. So we'll start with Gary from Pacific Source.
Hey, thanks. We just submitted the written comments. There was just 2 issues. First is regard to the partial approval. When our people were looking at it, they're trying to think to have language in there that's broad and all-encompassing, so there would be no across the industry questions. And so we proposed some language that just brought it up a level, maybe not so much detail. Now, again, I don't know if that's going to cause problems other places, but it's one of the things that we want to bring attention to. The second one was the flexibility in the format of the NQTL. Some sideboards on there. What we were thinking is if there's a format approved in another state, so that those carriers that operate in different states, if they want to try and use one template that can meet all the country needs, that would be great. Again, we understand if the Oregon wants to say nope, it's this format and nothing else, but just try ease of implementing this new requirement. I'm trying to understand what information is going to be coming in to the regulators. This is new type of approach that's being required. So we thought allowing some flexibility, and if we find out in 5 years or 6 years it needs to be more specified, then we can always come back and address it. Thank you.
Great. Thanks, Gary. Next up, we have Antoinette from Cambia.
Yes, good morning. Well, our concerns was mainly on the medium maximum allowable reimbursement rate. We wanted to know where items like providers receiving care coordination fees, grants, or other forms of payment outside of reimbursement via claims-based billing, where those items will fall when calculating the median. We also recommended that the definition could benefit from greater specificity, around what is paid versus claims. What is paid via claims versus all other forms of payment. And then lastly, also excluding other forms of payment could have the consequence of reducing the median in aggregate if those non-claims forms of payment replace some claims-based payments. So those are the items that we wanted to primarily bring to your attention. And then the others was just clarification around the operative days, which I believe you clarified outside of the letter. So we're good to go. Thank you.
Thank you, Antoinette. Next up, we have Tim. Oh, Gary, do you have a question?
Yeah, I just want to clarify, there was one other comment we had is in regard to the use of claims in determining that we turn in its incurred claims. We support the use of that. At the last discussion, it was, do we include information from provider agreements that may never submit such services? And so we were supporting incurred claims. Sorry.
No problem. No problem. Thank you for adding in the rest of your comments. All right, Tim, we'll go to you.
Sure, thanks, appreciate it. And I submitted comments pretty brief just about the collection format. And first, before I get into that, I share the industry's desire for flexibility. This is a new process, so I think that flexibility does sound reasonable. And I don't think that the tools we discussed last week, the Illinois tool or the tool that was submitted to the NAIC regulator-only parity working group, I don't think the tools itself are going to make or break the comparative analysis process. I just want to make that clear. However, my comments were putting a plug in for that tool that was submitted to the NAIC working group, primarily because one, I know it's in use already by 6 or 7 other departments, and that's just that they've told me. I found out yesterday that another department, in fact, is going to be using it. I hadn't been aware of before. So I do think that might end up being the uniform tool. But that being said, there also is a substantive reason. The tool that was submitted to the NAIC has a integrated response for the comparative analysis, whereas the Illinois tool has 1 column for mental health substance use disorder, 1 column for medical surgical. And while I think that side-by-side approach is fine for some of the steps in the comparative analysis process, I think for some issuers, and I'm not saying anyone here, I'm just saying that for some issuers from what I've seen, the side-by-side approach invites them to describe things for behavioral health, describe things for medical surgical, but not actually do the comparison. So I think a unified integrated response format is more appropriate for demanding comparative analysis. And that being said, I think either tool would be fine. And I also just recommended that the department reach out to either Jane Beyer, Katie Zurich, or both at the parity working group, the NAIC. And that was it. Thank you.
Thanks, Tim. And we'll let everyone on the RAC know that we have reached out to Jane Beyer because she is our kind of counterpart over in Washington. We talk about many things, not just mental health parity, but we have made contact with her about this and the stuff that she's been doing in the working group with NAIC. All right. Thank you, Tim. Moving on to Bennett and your comments.
Thanks, Cassie. Yes, since the last meeting, I had an opportunity to have a conversation with a colleague of mine who's involved in primary care behavioral health integration. And one of the things that had not occurred to me when we're talking about the time-based codes that are included in the legislation is that they're time-based health and behavior codes. And I'm not sure that the intent of the legislation was to include these codes, but I thought it was worth bringing up here because the situation that was being discussed is a situation where when you have a mental health carve-out, sometimes these codes then don't get paid because the medical plan hasn't credentialed the provider because the carve-out credentials the mental health providers in primary care, and then the mental health carve-out does not want to pay the health and behavior codes because it's not looking at those as therapy codes or, time-based therapy codes. Given the high priority the state is placing on behavioral health primary care integration, I just thought this should be addressed here.
Thanks, Bennett, and we will discuss that further with the group later on. Moving on to Melissa.
Yes, well, so the document that we submitted centered on the issue of using incurred claims data versus contracted rates data. And when it was brought up during the last meeting, by Gary, it sounded good and definitely worth considering and thinking about, and which, we did, and we started discussing it and really just identified multiple ways where we feel like looking solely at incurred claims data has the potential to muddy the waters rather than increasing transparency and gaining the clarity that we're really trying to get at here, which is, are the insurers showing a willingness to invest in mental health treatment? Are they complying with parity as applied to reimbursement? And we really think that looking at contracted rates data is the best way to get at that information. We don't have a problem with looking also at incurred rate claims data, and that might even give us a fuller picture, because if an insurer is showing that willingness to invest, but yet the network is still inadequate, what's going on there? So where is the problem occurring? So we just want to make sure that there is compliance with parity and that there is an intention by insurers to invest in mental health, and what actually happens out in the field would of course be shown in the incurred claims data.
Great. Thank you, Melissa. We will move on to Dan from MODA.
Thanks. So I jumped ahead a little bit to area that the rules that we've been talking about haven't addressed yet, but I just wanted to put in a plug for allowing sufficient flexibility that if a plan and a provider want to contract using a method that differs from the methodology that plans use for medical providers, that we not be sort of put in a straitjacket that prevents us from entering into a contract that both parties feel is favorable. And I gave some examples of where that might be necessary, including like community mental health programs, where there's no RVU available for the HCPCS codes that they bill most frequently. And so being able to, do fee for service when that is deemed most favorable by the provider and the payer.
Great, thanks, Dan. And I'm sure we're going to have robust conversation. I've heard from a couple of you about the methodology in particular, and that'll be more of the fun to come when we get done with the reporting requirements. Is there anyone else, any other RAC members that I kind of forgot to include your comments or have comments that you would like to provide at this time? All right, seeing none. Thank you all for submitting your written comments. I thought that was really helpful for us in kind of reviewing the conversation that we had last time, and then also having that additional information as we kind of continue refining our draft rules for reporting requirements. So we will head into that section of our agenda to start the discussion on our draft rules. We did we did kind of a review of all of the comments that were made during our last meeting to make some changes related to that, and then also tried to identify in the bullets some areas where we want to have some further discussion with the RAC. So Karen, when you get a chance, if you want to pull up the draft rules, so we'll have that on the screen here. Alrighty. So I think we'll first go down to the definitions, in particular, starting with the definition of incentive payment. We kind of put together a definition that is based on some of the federal rules around kind of defining what an incentive payment is. Would love to hear your feedback if this captures some of the kind of concerns of needing more specificity about an incentive payment. If there's anything that we missed, would love to hear the RAC members' feedback.
Cassie, this is Antoinette from Cambia. Would we get another chance to provide feedback after this meeting? Because I would like to cross-check it with our subject matter expert first.
Yeah, we will have another kind of round of written comments for the draft rules. So if you need to take this back to your teams, that's totally fine. Yeah, Dan.
Thanks. I have two comments about this definition. One is I would recommend substituting provider for physician, because many of the providers are not physicians. The second thing is I'm confused by the language about may directly or indirectly have the effect of reducing or limiting the services. My thought about incentive payments would be that it would be the opposite. Like if we're paying a care coordination fee or a bonus for somebody meeting, taking extra steps to meet a HEDIS measure, for example, that would not be reducing or limiting the services that the enrollee gets, but it would actually be improving the services the enrollee gets. And so I was just confused by that language.
Thanks, Dan. I've made note of your comments. Melissa.
Yeah, we were also confused by that and wondered whether there, I don't know where this definition came from, but wondered whether there might simply be a typo that maybe it's supposed to say may not directly or indirectly have the effect of reducing or limiting. That was one of the questions we had, is if maybe a word was omitted, because that part was also confusing for us.
Lisa.
Just to give some feedback on your concerns about it being confusing, this was pulled from the Cornell law definition. And so this is really good discussion about that point. So we'd have to do a little bit deeper dive into why it's defined that way.
Yeah, on further reflection, I guess, if you think back to the old HMO model where, providers may have gotten incentives for providing less services or something, it might be that, but I don't know that that really reflects the way incentive payments typically are used these days.
Understood. Thank you.
Yeah, I think we'll take another, Bennett, were you going to say something?
Yeah,
Yeah.
I agree with this discussion, but actually my experience over the years is if you do a good job, you may use less service. So we certainly don't want to get in the way of that.
And perhaps we'll take another look at this, but especially in relation to that like final part about the effect of reducing or limiting services. But does the rest of it make sense in terms of a compensation arrangement that includes but is not limited to coordination fees, withholdings, bonuses, capitation, or other compensation? Are there pieces missing that need to be further clarified in kind of how we define what an incentive payment is? Melissa.
I'm not sure if it belongs here, but I just wanted to make the point again that we made in our memo going into the second RAC meeting is just that, we want to differentiate between an incentive payment. The way that we are viewing incentive payment is it's a payment that happens when a provider or provider group is doing something extra that is beneficial to their patients, and that is based on providing higher quality value-based care. And so they're doing something extra, therefore maybe they're getting paid extra for doing that. Maybe they're doing outcome measures, who knows what it is. And we wanted to differentiate that from a situation where a provider group negotiated higher rates because of their larger size or having a significant market share.
Dan.
I think maybe the key feature of an incentive payment is that it's paid outside of the regular claims adjudication process. So, you bill 90837, we pay you X amount of dollars. And that's attached to that particular member, whereas incentive payments tend to be more population-based, maybe based on meeting certain metrics, and happen outside of that regular claims process and not attached to a certain CPT code for a certain member.
Melissa.
Yeah, thank you for that, Dan. And I guess I just want to say that, we're shooting in the dark a little bit here because, as a mental health provider group, we only know what we know. And so we don't know exactly how you do these incentive payments. And that's where I appreciate your guidance and hope that you can, that the carrier representatives can contribute to this discussion by letting us know what this actually looks like and helping DCBS figure out how they can parse that out, or whether certain things need to be included versus excluded.
Yeah, I would kind of open up the opportunity if one of the insurers wants to kind of give a little bit of background on incentive payments and how they're typically used in this space. In general, I think that might be helpful for the RAC members to understand kind of this space in terms of what are things that are included as an incentive payment, when do they usually come up. I think, Dan, your background that it's usually paid outside of a claim is really helpful, but are there other aspects that would be helpful for us to kind of define what is an incentive payment? Gary.
Yeah, I can't speak, across the board for all carriers, but I know that there is some where you'll look at case by case, depending on the diagnosis and how well that case is managed. I think that may go to a little bit on Dan's metrics. They get outside the usual payment for a particular code. Some carriers look at, how well is that physician or doctor managing the diagnosis or the condition, and may use that in their contract agreements. So it does get outside the fixed, whatever that negotiated rate is. What I struggle with is trying to find the language to use or the words to use that you could do an all-encompassing of what you guys are talking about. I'm just not sure. I don't think the definition that you have here gets to it of truly what you guys are meaning by an incentive payment. And that's where I'm struggling with. That's why I'm a little quiet, just thinking in my head is, how would you write that? Because each carrier is unique, and and trying not to call out every single one in a rule. Just being sensitive to that issue is, can we put some type of language there that captures everything? I haven't yet, and I may have to go back to my provider folks and get more input there.
Thanks, Gary. Yeah, I think we'll have to think through this internally, and also relying on the comments that you all kind of send back to us in terms of what encompasses an incentive payment. I think some of the language that we have in here is including but not limited to, which might provide some And Karen, can you go back to the rules? Thank you. I think, it might provide some of the high level ones that are used typically by insurers, but maybe there are, unique situations for different carriers depending on how they structure their incentive payments and whatnot. Melissa.
Something that may help us think about this is what, to think about what codes we're actually looking at making comparisons on. We are primarily concerned with these time-based office visit codes. And so it may be the case, again, I don't know, because I don't know what I don't know about incentive payments and how they're paid out, but it may be the case that these office visit codes perhaps do not have incentive payments tied to them. I don't know how that works exactly, but that might be useful as to, rather than thinking of every possible CPT code out there, to be really focusing on the time-based office visit codes and how we can get at that information and whether incentive payments are something that could muddy the waters. Perhaps this isn't as much of an issue as we're concerned that it is, but ultimately we really just didn't want insurers to be penalized for paying an incentive to providers, whether they're medical or mental health, who are doing something extra.
Great, that is helpful background. Any other thoughts on incentive payments? I think we've got some work to do in kind of clarifying that. Gary.
Hey, just quick follow-up on Melissa's is it would be good to hear from for the mental health providers, the different is just a couple examples of the incentive payments that they may receive. We keep on asking what the insurers pay, and we'll do some digging on our side, but from the providers, I mean, in your space, what kind of incentive payments do you guys see being offered by health plans?
So I don't see anything, to be honest. I'm a solo practitioner. I'm not part of a group. And so there isn't anything offered on my end. I have never received an offer from anyone to participate in any program that would allow me to receive incentive payments. I can't speak for larger mental health groups, but the thing that's unique about mental health providers as opposed to medical is that many of us, most of us, I would argue, do tend to be solo practitioners or part of, small practitioner-owned groups. And so, like I said, this could end up not being as much of an issue as we think that it is. We were really just thinking, how can we get at the comparison that we're looking to make between medical and mental health. But yes, that's not ever been, that's why I know so little about it.
Okay, thank you.
Are there any other RAC members that might know what kind of incentive payments providers do receive from kind of the provider side? And if not, we can feel free to include it in your written comments if something does come up, if kind of your conversation with colleagues or as you're thinking about how we define an incentive payment, if there are those things. I think it's important to hear from both the providers and the insurers on kind of what the incentive payments do look like. Okay. And while we're on the definitions, we can take a quick look at partial denial and time-based office visit. Do these changes, Bennett, yes.
Yeah, just I'm sitting here thinking about it because I haven't been in private practice in a while, but and maybe the insurers can say whether this is relevant at all, but the largest CCO in the state pays for services. Most of their payment is through case rates. They do pay fee for service for individual practitioners, but most of their payments are through case rates. So I don't know whether you all are using that, whether you would consider it an incentive payment, but it's not based, it's not a code-based time, although on the back end, the way HealthShare does that is you have to fall within certain guardrails of utilization to get paid the rate. And you can get paid more if you exceed it and less if you don't make it. So I don't know if that's relevant to this discussion or not.
Dan.
Thanks, Bennett, for that point. I would say case rates in the commercial world for behavioral health are extremely rare. One of the reasons for that is, as Melissa said, there's so many of the mental health providers are onesies and twosies, small groups, individual practitioners. And case rates, as I understand it on the CCO side, particularly historically, has been sort of more population-based, where you've got, say, a community mental health center that manages an entire population, and they get paid for that. And given the way that mental health services are provided to the commercial world, we just really don't do that. We do have some limited case rates for like specialty programs, like, with one provider, we've negotiated for a case rate for residential treatment. So rather than paying a per diem, it's per admission. And a few things like that, like for a pain management program, it's a case rate maybe per month. But by and large, I think when we're looking at these time visit office codes that the bill really is focused on, I think the case rates are not applicable.
All right, that is all very helpful. Thank you all. Anything else with incentive payments, or any thoughts about how we kind of made the changes to partial denial or time-based office visit? Bennett, your hand is still raised, but is that from the last time? Okay, great. Just wanted to make sure. All right, if those look good, we'll continue on in reviewing. We'll move on to kind of moving through form and manner. I know that Gary, you brought up kind of some comments about flexibility with the templates and whatnot. I think we can still have a conversation about that, but kind of when we took this back to our folks internally, one of the things that we talked about is, right, out of this reporting, we have to make our own report out to the legislature. And I think it would be easier just in terms of data analysis and information collection to have a standard template that everyone follows. We haven't made a decision on which template we will use because the rules give us some flexibility about kind of what that would look like. But that's sort of where we're landing, just to help with the back end data analysis in terms of having kind of compare an easier apples to apples comparison between different insurers and reporting. I see Jen, your hand is up.
Hi, thanks, Kathy. And I know I had mentioned this to you in a previous conversation, but I just wanted to go on the record and say, there was a lot of discussion around this flexibility, and while Providence advocates for that flexibility in the templates, because we've already begun that process at the federal level, we definitely would object to the Illinois template because it pre-populates the NQTLs, and when the federal guidance explains that the carriers should provide their NQTLs and their specific NQTLs, so we would, encourage you to go in a different direction. We'd actually advocate that you use the Word document as the template that you proposed And we go from there. But that's kind of where we were at on that one. And I just kind of wanted to put that out there.
Thank you. And I see that we have another hand up from Randy. So we're going to keep comments to the RAC members right now.
Sorry. Yeah. So this is Randy. I'm actually with Providence and I work with Jen Baker. But
oh,
Jen
okay.
just
Okay.
expressed the exact sentiments I was going to say. So we're good.
Awesome. Thank you, Randy. Appreciate it. So any other thoughts about the kind of form and manner? Like I said, what I think we'll do is once we have kind of the rule text finalized, is we can have a deeper conversation about the templates and how that reporting will go. But kind of focusing on the rule language itself, so we can get that kind of official process started, because it takes a while to go through to get it to being finalized. But definitely still some time to have conversations about the templates and what they look like and which ones will work best. Okay, we'll keep moving on. To the next section, which is, I think that we'll move past all the federal kind of reporting requirements, since folks don't have any issues with those, and we'll go to starting in this, all the other kind of quantitative additional information that should be included. We did make some changes about the denials based on the conversation that we had about partial denials and full denials of reporting both, but being inclusive of all of them, as opposed to having them separated out into two different reporting elements. For the percentage of claims, very similar based on our conversation with partial denials, just to make sure that it includes any of those partial claims, if that still makes sense. And then we will move on to the median maximum allowable reimbursement rate. And there's a couple components I think that we should discuss as part of our conversation today. And that is this. I think comments were made from several RAC members about the provider contracted rate and the incurred claim rate. So for right now, we have both included, and would love to hear feedback about kind of if there would be issues reporting both, if there are, if it would kind of not be as accurate. I kind of open it up to the RAC members to provide some feedback to us about the kind of the decision point between how that reimbursement rate is calculated, if it includes both of those, if they're separated out. So you have a median maximum allowable reimbursement rate for provider contracted rates, and then a median maximum allowable reimbursement rate for the incurred claim rate. Would love to hear RAC members' thoughts. Dan.
Dang, I always want to not go first. I try and hold back. Melissa raised some really good points in the letter about how if we go on incurred rates or incurred claims, how that could be distorting in terms of the effect of large clinics versus smaller individual providers, in terms of providers who may decline to take patients from a particular payer or take fewer of them. And so I was thinking about that a little bit. My concern is I'm not certain that we're able to report out on contracted rates. I've sent an inquiry to our manager of provider analytics to ask about that, and her response was, I think we could, basically, but it's not something we're used to reporting on. It's not, so there could be some technical issues with trying to do it for the universe of contracts, and there could be some distortions with that as well, as we talked about last time, in terms of, contract that hasn't been touched in 15 years. And that's not just a medical, or not just a behavioral health contract, but that's a medical contract as well. And so there could be some distortion that way. I think one possible way to minimize the distortion based on incurred claims is if we basically report only once per tax ID, per CPT code. That way, let's say you've got a Peace Health that has hundreds of practitioners. You'd only count that once for each CPT code, and a private practitioner would also get counted once for each CPT code, assuming there was any claims at all. That wouldn't solve the problem of a practitioner who didn't see any patients from that provider, but it would definitely, I think, level the playing field in terms of large providers with negotiating power versus smaller providers who don't have that negotiating power.
Melissa.
So I'm thank you for your comment, Dan. One of the concerns that I have about what you're saying, and correct me if I didn't hear you right, but reporting once per tax ID, the problem with that is that a large group that is all working under one tax ID is only going to be counted once, and maybe they have 20 providers or 50 providers or 100 providers. And we're really concerned about how this links up with network adequacy. And so, that's, I think, even more of a reflection of our concerns about using incurred claims data and the potential for the waters to be muddied. We understand that insurers are not used to being transparent about contracted rates. And that's why we were, wanting this measure of central tendency to, kind of allow you to come up with a representative number rather than sharing actual contracts and fee schedules, because we understand the limitations to that. But it just, when we think about incurred claims data and start thinking, how are we going to get at the information, then it gets very convoluted and complicated. And there may be folks from DCBS who have been doing this, maybe Tasha, who can, add to this discussion. But, in our memo, that's what we expressed, is just the potential for things to get convoluted. And then ultimately, I think it was Gary, he asked the question last time, what are we trying to get at? And that, I really took that question to heart. And like I said earlier, we are trying to get at a carrier's willingness to invest in their mental health services and whether they are complying with parity as far as reimbursement goes and network adequacy. And we still think that the best way to do that is to look at the contract rate data, because there's just too much potential for things to get convoluted if we're looking at claims data. And then the concern I also have is uniformity. DCBS is going to have to figure out how to communicate to the insurers how to extract the data that they want. And there's just so much potential for for carriers to perhaps do things a little bit differently, or for a mistake to be made. And we just think that the simplest way to get at this is to just go straight to the source, which is the contracted rates, and to do that for every provider that is in the network, not just one provider group.
Jen.
So that's a lot to unpack. So we would oppose, Providence would oppose, obviously, and we agree with some of the other carrier comments on including contracted rates. And I'm confused, and I'm opening this up for a discussion, but I'm confused by what Melissa's saying. It muddies the waters because I feel like the claims data provides way more uniformity than the contracted rates, especially when you do have carriers contracting in different ways. And it's not necessarily that we're not trying to be transparent. It's that we don't have the mechanisms to report that data the way you want it to be reported, whereas the claims data is readily available. So, again, we'll provide further comment on this in writing, but we would oppose using contracted rates, not because we're not trying to be transparent, but because we feel like it will provide more uniformity.
If I may, one example that I can give, and on the mental health side is when you look at what is on a claim, how are you going to get at what that provider's contracted rate is? Because I don't know that this happens on the medical side, but on the mental health side, we have such a huge range in terms of our contracted rates and the maximum allowables. So from the lowest payer to the highest payer is a massive range. And so I, for one, and the other thing is we're more likely to work out of network or to work out of pocket with clients than I think medical is likely to do. And so my full fee is what we would call, the fee that I consider my full fee that I would bill if I were going out of network is actually lower than what my highest contracted payer would pay me. And so if I'm billing, I'm just going to throw out fake numbers. Let's say that I'm billing $150, but that payer would actually pay me $180, then on that claim, you're going to see that, and you're not going to see that payer would actually be willing to pay me $180. And you're only going to see that in the contract. You're only going to see that in, looking at their methodology. And so that's just one example. And, when you look at that claims data, you've got to extract things such as copays, coinsurance, deductibles. There's just a lot to go there. And Jennifer, to what you're saying, I don't know how difficult it would be for you to get at contracted rates data, but I don't. Yeah, it just, I'm having a hard time understanding why that would be difficult to access that data, because every provider in the network has some sort of a contract, and included in that contract are their fees. So that might be helpful to hear a little bit more about that.
So I'm happy to discuss in our comments more reasons why we oppose the contracted rate. But also, I think there's another consideration behind what determines a contracted rate. A contracted rate for medical services may include administrative overhead, which is different from what our behavioral health contracts, particularly for behavioral health, often who are doing solo practices. And so that's something that we really want to consider. Contracted rates don't necessarily, there are other considerations that we have to consider what determines a rate. So, I mean, how do you factor all of that in? And we'll put this in writing.
So I would agree with what Melissa said about the possibility that, if the billed amount is less than the contracted amount, that would distort the results if we're going based on claims data. I'll also say, dealing with the deductibles, co-insurance, co-pays, that's completely easy. We do that all the time. You just go based on allowable amount. And that gives you an apples to apples. It doesn't address the thing about if the billed amount is less than the contract amount. But I think that is a relatively rare phenomenon, and if anything, would make probably look less favorable for providers for mental health than for medical. But my concern would be, again, the distortion. There's going to be some distortions either way. My gut feeling is the distortions would be greater if we go by the contracts, and definitely more difficult to report than if we go by claims.
Melissa.
And I think that's where including both types of data can, give DCBS the most complete picture, because, this is new to all of us, and this is going to be new territory, and that we're navigating here. And so, looking at both types of data is I think going to give the most complete picture. I'm definitely looking forward to, getting more information about the difficulties associated with looking at contracted rate data. I don't know how often that gets updated. It appears that there are some carriers who update their contracted rates yearly or fairly often. On the mental health side, I can't speak to the medical side. There are some carriers who have not changed their contracted rates for a decade, which in and of itself seems a bit troubling. And so that's the kind of stuff that we're trying to get at. But
it's very common for providers not to update their contracts with large medical systems for multiple years. Multi-year contracts are very common in certain circumstances and not in others. So, I mean, I think that's, again, I feel like you're trying to portray us like we're only doing this to provider health or behavioral health providers, and that is completely an inaccurate portrayal.
Okay, and I'm not intending to do that. I guess, the purpose of this report is to figure out what is happening and to see if there are inequities. And if we find out that there are not inequities, that's great news. And then we're also trying to figure out what's going on with networks and network adequacy. And so, in my mind, the purpose is how do we best get at that information. And, I hope, if for those of you who haven't read the OIMHP memo that's attached to this meeting, hopefully that will give some more clarity on what we were thinking.
Bennett.
Yeah, thanks. I find this conversation interesting and a little circular, and I can totally, because I've been on the other side of this, see the insurer's point of how do you get this data. On the other hand, my personal experience has been that the contract amounts can be important. So, when I was practicing in Astoria, and frankly, I think at the time the only psychiatrist in the county, a carrier wanted to drop my rate to less than the Medicaid rate. And when I said, well, I'm the only psychiatrist here, we got plenty of people in Portland. In that case, I said, well, fine, I don't need to contract with you anymore. Or actually, that's another story. So, and I'm trying to figure out how you capture that kind of problem. If you see what I'm saying, where you are offering rates such that either people don't accept the patients, as Melissa said, or they drop the contracts. And so, which has impacts on providers, but it also has impacts on this whole issue of ghost providers and ghost networks and all of that kind of stuff.
All right, we'll go to Gary and then Melissa.
All right, thanks. Hey, in looking at this, can the DFR comment on what they're going to do with this data? If I'm just looking at some concerns with trade secrets on the provider contract rates? Are you going to aggregate it, put in totals? What happens there? Because that's what I'm also looking at too. I think we can do provider contractor rates, but it's the releasing of it and how it's released. I know that's been raised some concerns internally at Pacific Source, putting that out there. Because if you look at this, if you're going to put provided contracted rates and then out of network providers information, the out of network's probably not an issue, but it's that provided contract. We generally keep that as a trade secret. So if the DFAR could give us a little insight on, what if we turn in this data, what happens to it and how would it be presented outside? Thank you.
So, I guess Cassie, if you don't mind, I'll start. This is Tasha Sizemore, like a health program manager for those of you who I've not met before. Gary, I guess generally what I would say is I don't talk about trade secret unless my trade secret public records request person's on the phone, and she's not here right now. So I will get back to you kind of generally on where this would fall within the trade secret requirements, and that's something that Cassie and I can follow up on.
Go ahead.
That being said, the overall question about what we would do with this, I think that there's documented evidence in on NAIC or I guess other regulator examinations and work data calls that have been done that have demonstrated that the frequency of contracting, that there's disparities in those contracting processes between physical and mental health for some insurers. This is just broad nationwide assumptions. Seeing that information would help give us more insight into what, are you guys complying, or do you have a company practice of providing less opportunity for contracting for mental health than physical health, for example? That may help us identify those pain points and resolve them for our market. And what I could say is, Spencer and I have a lot of conversations, and sorry, Spencer, I'm going to throw you under the bus with me here a little bit. We have a lot of conversations about protecting that data. And the one thing that Spencer and I do a lot of is making sure that if there is a request for information, that first of all, if we're going to give it, and if we're going to name insurers, or if you could be implicated because you have a different business model from the other insurers, I always pick up the phone and call and let the insurer know, like, hey, this is going out. And I know Spencer and I talk about this all the time. We want you guys to be prepared if we do have to release it. So, I would use it under the confines of compliance for day-to-day work, but we would also protect it if we do have to release it. And then I will get back to you on the confidentiality piece. I'll need to consult with Gail Gage on that. So.
Thank you.
Yeah.
All right, and agreed with all the things that Tasha said, that we'll get back to you on kind of the specifics of that and how we can best go about that. And we've dealt with this in other types of reporting with you all and myself with standing up a drug price transparency program. So we'll take your concerns and come back with more information later. Melissa.
Yeah, just briefly to follow up Bennett's comments, which I appreciate. That is one of the points that we put in our memo, is that when providers are trying to figure out whether or not they want to join a network or whether they want to stay in a network, that is based on their contracted rates. And any provider that's looking to join a network is gonna make that application and is gonna look at what the contract says, and that's the reason why we think it's important to get at that specific data.
Bennett.
Yeah, it strikes me, although this is not what the law says, what my experience of contracting with insurance companies is that there was basically a standard contract that you got that had a standard rate, and then in some cases you could negotiate. But there was always a kind of It appeared to be a standard ask. And that does not fit into the statistic that got written into the law, but in some ways, that's what you're really wanting to know, is it not? I mean,
yeah, I would say so. You know, that is what we're looking for. Because, and you know, again, in mental health, my experience and the experience of colleagues is that we aren't usually given the ability to negotiate. And so what that base offered rate is very important to us, because often that's a take it or leave it for us. And that's just the reality of the situation. And so what we're trying to figure out is just, you know, we're looking at trends between medical and mental health, looking for disparities, trying to figure out what the floor is. We're not as concerned about the ceiling. The ceiling can go as high as you want it to go. We're concerned about what the floor is, and whether the floor is, you know, kind of climbing in tandem or being lowered, and how that affects providers wanting to be a part of a network, which ultimately then affects access to care.
Dan.
Yeah, and I think the median is going to get us pretty close to that standard. I don't know for certain, but you know, if more than half of your providers are on that median, then that's, or on that standard, then that's what's going to come through when we report on the median. So in that respect, I think that the law was well written.
All right. This has been a great discussion. Just in the interest of time, I'm going to move us along to some of the other points that we can hopefully get to. Continuing in median maximum allowable reimbursement rate, I think there were some comments about if this should be for in-network and out-of-network, just in-network. Want to hear if there are any thoughts about kind of reporting on those types of providers. Melissa.
I feel like I'm talking a lot, but nobody else is saying anything. So I will just say, I know that there's somewhere in the bill where they do want to look at out of network, and I don't have it specifically in front of me, but I will say this is some of the practices that I've seen that were surprising to me when I was in network with a carrier and then made the very difficult choice to leave the network. But I continued to see clients that were still members of that insurance, and then I became out of network, is that that particular carrier set their out of network reimbursement rate actually lower than their in network, which I didn't even think that was a thing. I didn't think that was ever a practice, but I saw it with my own eyes. And so the effect of that was that this person, not only did they have to pay a higher portion of the allowed amount, but the allowed amount was actually lowered even further. And so the insurer, let's say, you know, pays 50% of that lower allowed amount, and then it gets put on the provider whether or not I'm going to balance bill that person. And then that person ends up paying much greater than 50% of the full charge. And so if I hadn't seen this practice with my own eyes, I might not even, you know, be too concerned about it. But that has personally happened to me.
Dan.
I would just say that's common on medical as well as behavioral health.
And Rachel, you raised your hand. Did you have something to say? Oh, okay, great. Just wanted to make sure. All right. So if there are any other thoughts, please include those in written comments about kind of the provider types that this is applicable to. All right, moving on. The final piece in median maximum allowable reimbursement rate is including some type of description of how incentive payments were identified and removed as part of the calculation for the reimbursement rate, just to provide some context. I think some of our conversation previous about incentive payments illuminates possibly why this is helpful to include if there are differences between insurers or provider types that receive different incentive payments. That can be noted in a description that is reported to us. Dan.
The Melissa and Dan show. So I don't think it works that way. Incentive payments, would not be removed from that calculation because they're not part of that calculation in the first place. As I said earlier, my understanding of incentive payments is that they are provided outside of the claims payment process, and not attached to specific claims for specific codes for specific dates of service and members. So we might want to be a little more general about a description of how incentive payments may affect the overall compensation for providers. Just something a little bit more general. I don't know. I don't have exact language in mind, but.
Yeah, and perhaps I can provide some clarity about why that was included. So the definition for median maximum allowable reimbursement rate in the statute is the medium of all maximum allowable reimbursement rates minus incentive payments. So that's kind of the impetus of that description of like how were they removed from that rate calculation. I guess like not going back to like the conversation we had about removing it from kind of service payments or whatnot, but more in relation to the statutory definition and how that calculation was made. Does that make sense?
It makes sense that that you're following the language of the law. I'm not convinced that it makes sense from a reporting standpoint that if we would be able to provide any data that meant anything in that precise respect.
Okay, we'll take a look and see if we can make it more general. I just wanted to capture, right, like if there are differences in calculation, how do we capture that and acknowledge, right, those differences that may or may not be significant to our comparative analysis. All right, we'll move on to time-based office visits. I know, Bennett, you had some comments on this, and I'm not sure if others in the group have kind of more information related to kind of this concern about the behavioral health codes and interacting with the medical side of the benefit. I'm not as familiar with that, but I wanted to bring it up as an item for conversation. If Bennett, if you have anything further to add, or if other RAC members have kind of reaction to the kind of issue that Bennett has raised.
Yeah, I think it's been a while back. I think I said it as clearly as I could. And once again, I'm not sure that the current legislation meant to address this, but it is a significant problem. And I hate to see the care of people in primary care being inhibited by this kind of thing. So I don't know whether anybody from the insurance side has any comments or thoughts about this.
And if not, Dan, go for it.
Yeah, I think it's a legitimate issue, and it really does relate, as you said, Bennett, to the issue of carve-outs. I'm not sure how you would capture it either. the issue really isn't the amount so much that gets paid as whether it gets paid at all. And when there are carve outs, I know that's a significant pain point.
I mean, what's interesting is that you don't require a psychiatric diagnosis to bill those codes, but they are behavioral health interventions. So, I wonder whether in this rulemaking process, we could say that they are behavioral health codes and should be paid for that way. I mean, in other words, that would then eliminate this hot potato situation as to who's responsible, which part of the plan is responsible for paying that code.
Jen.
So my comment isn't necessarily in response to Bennett, but we did have one question from our contracting team. They want to understand what is in scope for time-based visits. That it's E&M is clear, but non MDS behavioral health providers bill time-based visits, but there are no comparable codes for physical therapy or something like that. So, and again, we'll provide more comments on that, but that was a question that I got from our team.
Great, thank you. We'll look forward to getting more of those comments so we can think through how we handle the time-based office visits. And then I think, Bennett, to your point, I'll need to dive in and maybe talk with you further so I can understand the issue. But it could potentially be part of like the other data and information necessary to kind of report on. There's that potential if this is an issue that we should kind of investigate further. Like I said, I'll need some more information to kind of fully understand what's going on with it.
We could take it offline. That would be fine.
Okay, great. All right, so we've got 15 minutes left, and hopefully we can make it through the rest of the rule. These are the parts that we haven't had a lot of conversation about, just because we've had robust conversation about all sorts of other things like medium maximum allowable reimbursement rates and CPT codes and denials and things like that. But the last part of the statute requires insurers to provide descriptions and documentation on the policies, procedures, and other efforts to maintain compliance with the federal law. And then also with the state law, which is ORS 743A 168. So want to have a conversation about what data elements might be helpful in this, or kind of leaving it open-ended. And Jen, you have your hand raised, so you can go first. Jen, do you want to go?
Sorry, I'm trying to.
It's all good.
Juggling screens here. So, I'm curious where you're going with by adding section 5 here, because it's overly vague. What are you trying to get at with this? It's very, very vague and could be extremely administratively burdening on a health plan. So where are you going with this? What exactly does providing descriptions and document on the policies, procedures, and other efforts to maintain? I'm just looking at the screen and trying to look at y'all, but and then on section 6, I mean, I can either give you time to answer that, or I can jump to section 6, but I do have some comments on that as well.
As far as 5 goes, I think I would kind of love to hear if there are aspects of the federal law that would be of interest to kind of look at for compliance, but I know we do have all of the reporting up above in terms of the NQTLs. Like I said, this is part of the statute that is one of the kind of requirements for reporting. So we want to make sure that we have that specificity. If it's like you're saying, Jen, of like what exactly would be helpful in this space for reporting. And I see that Chris, you have your hand up.
Yeah, so I just had a kind of a question in this area, which is, you know, the reference to policies, procedures as the state law, you know, changing under the bill starting in 2023. Is this written in a manner that as those new requirements in 2023 come into effect around the use of level of placement instruments, and then the requirements under treatment criteria meeting generally accepted standards of care, is this written in a manner that would allow the division to systematically obtain the policies from carriers around those two particular pieces?
And so I think, Chris, your comments are related to the state law.
Yeah, because the state law attempts to articulate the federal law in the manner that it was interpreted by the U.S. District Court in the Witt versus United Behavioral Health decision. So, you know, there's the definition of generally accepted standards of care, and then there's the application of that and the limiting of instruments used during utilization management review on level of placement. And then there's a whole bunch of language around treatment criteria that goes beyond that, but has to hew to the generally accepted standards of care. And that all takes effect in 2023. And so the conversation on our end is around making sure that the division has the ability in that reporting to make sure that carriers are disclosing how they're playing that out in a manner that so there can be analysis that it's being done in compliance.
Great, thank you. Jen, you said you had some comments about this section as well.
Yes, sorry. So for this section, we find that it pertains to qualitative treatment limits, co-insurance, et cetera. It seems to be bleeding that into the NQTL analysis. And there are a lot of items in these rules and what they've written that doesn't seem to be as focused. And the other question we have, isn't this already substantiated through our yearly network adequacy reporting? It seems a little bit redundant. So why add it here?
Yeah, thank you for that. I think part of our thinking is to be responsive to the kind of the requirement to show compliance and to help provide some structure around that. And I know that we do have our network adequacy reporting, and that's why hopefully this isn't, you know, like can work in tandem with that type of reporting, but also has some other pieces that relate to how you're updating your coverage documents and policies, how the methodology is evaluated and at what frequency it's evaluated. You know, this is just kind of a first take of how we would evaluate that type of compliance and provide you a little bit more specificity than just the vague language of kind of providing descriptions and document on policies, procedures, and other efforts. Another kind of route that we could go with this is to, like Chris said, these won't be in place until 2023. We still will continue this rulemaking process, and perhaps that's a point where we can kind of further clarify what this reporting would entail at that point, since when you all report in 2022, this part of the state law won't be in effect quite yet. And so it would be difficult for you to report on. Just wanted to kind of start this conversation, especially because this is a piece of the reporting requirements. and would love to kind of hear feedback of if we specify it now or if we kind of wait as we continue the conversation that will kind of get into all of the updated statutory language for ORS 743A 168. And if there are, if folks are still thinking about it, you can feel free to kind of respond to what's been said about kind of this, of whether we specify it now or if we take it and specify it later. I think we would love to hear from all RAC members about how best to handle this compliance piece in terms of reporting for that. We are close to time, but want to very quickly go over the other data and information necessary to assess compliance. One of the things that I think that was mentioned at our very first RAC meeting, or possibly our last meeting, was including some information about telehealth and kind of how telehealth might or might not be different than other types of claims, and trying to get at that. So that's a brief overview of kind of what we're trying to get at for the other information necessary to assess compliance. I don't know if there are any initial thoughts or issues with this type of language of trying to get at telehealth and how that might or might not be different from other types of claims. All right. Not seeing any hands or hearing anyone. Please feel free to send written comments about this new language. We would really love to get your feedback and make sure that we are getting the right information from everyone. So moving on, I know we're running a bit low on time. I'll move into the public comment portion of our RAC meeting. Is there anyone here that would like to provide public comment to the RAC? All right, I am not seeing any hands for a public comment. If you are on the line and would like to provide public comment, you can send that to myself or Karen Winkle after the meeting. We're happy to receive written public comment as well. All right, so we've continued to have really great, robust conversation. In terms of next steps, our next RAC meeting is next week, so it's quick turnaround this time on September 30th. If you all do have written comments, which hopefully we can get some of that feedback, it would be great to have that by Tuesday of next week, so that we have time to review and make any changes needed to the rules. If you can get it in earlier, even better, because that will be helpful for us in terms of adjusting any of the rules or thinking through issues. In addition to our next meeting, we'll start talking through the SNFI, which is the Statement of Need for Financial kind of Impact. We'll kind of go through it. It's part of what this is we have to ask about the impact on small businesses and some other questions as well. So we'll have a draft of that for you all to review at our next meeting. And then also, if there are any kind of outstanding items for reporting requirements, hopefully we'll be kind of moving towards finalizing some of this language. And also through this RAC process, a reminder that we we'll post, kind of in the rulemaking process, these will be posted for a public comment period for which people can still provide public comment on the reporting requirements and whatnot. Laura, you have a question.
I do. Thanks, Cassie. Just a couple things. One, I know you guys are super swamped. If it's at all possible to get the draft rules more than the night before the meeting, that would be helpful so that I can run it by my folks. Two, I was wondering if you could remind us when the final, when the deadline is for submitting written comment on all of the rules will be. And I was just curious if you had a list of, I mean, there's many other portions of the bill right beyond the reporting. So when we might be getting to some of those, because some pieces are more relevant to my client than others. So I don't know if you have any light you could shed on those questions.
Yeah, thank you, Laura. So in terms of process, we are hoping to get the reporting requirement rules finalized by January 1st, just because the insurers have to report on March in March to us. So that was kind of the more time sensitive, kind of get that clarification in rule and have that available for insurers to reference. Kind of next steps after we finish our conversation about reporting requirements is to get into all of the other pieces of House Bill 3046. So that will be kind of after we feel like we have, a general consensus around the reporting requirements, and that will continue on its process to becoming a final rule, but then we'll transition to our RAC to talk about all of the other components.
Great. So you're saying that next week too, we're only focused on reporting requirements. Next Thursday, you're hoping to wrap those up.
That's the goal, is to wrap up reporting requirement conversation so that we can schedule out several other meetings for us to start talking about all of the rest of the bill. And appreciate your time and the conversation about the reporting requirements. And I'm sure we're going to have a lot of more robust conversation about the rest of the bill. But wanted to get this piece at least, finalized before reporting starts. Any other questions or comments? Alrighty, so if you all can get any written comments to us, preferably before Tuesday, but if you need until Tuesday, that will work for us. And we will do our best to get you materials as soon as possible after that time. Appreciate all of your participation and the conversation. And feel free to reach out to myself or Lisa or Karen if you have any kind of questions, and we'll keep kind of moving along in the process and getting everything towards a final state. Thank you, everyone.
Thank you.
Thank you.
Thanks.
Take care. Have a great rest of your day.
You do the same.